For non-radiographic axial spondyloarthritis specifically, what strategies can help reduce diagnostic delay and skepticism from payers who still see this as a softer diagnosis?
Right. So we do know that, non-radiographic axial spondyloarthritis over time will develop into radiographic axial spondyloarthritis. And non-radiographic just means that we can't see findings on X-ray. So if we don't see anything on an X-ray, then more than likely, when you do order an MRI, then you will see some subtle or early changes there that were not apparent on an X-ray. So I think the next step from there would be to do an MRI, and that should be very helpful in determining the diagnosis.
Mm. Some guidelines emphasize individualized treatment with NSAIDs as first line for axial disease. How has that changed your first maybe 6 to 12 months of management for newly diagnosed axial spondyloarthritis patients?
Right. So, there's been a lot of conflicting evidence about, what might be the best first line agent, but, more and more we are seeing, and even just recently, within the past like month or two, there was just more research published that showed that NSAIDs, non-steroidal anti-inflammatory drugs, these are particularly the long-acting ones or the selective COX-2 types, such as celecoxib or meloxicam, that these can actually slow down radiographic progression, which is our aim, right? We want patients to feel good, but we also want them to have a slowing of progression of their disease. So it still remains as a first line for now, just also thinking about the benefits outweighing the risk. We know that the second line and third line drugs carry, a higher risk of infections and, that sort of thing. So for now, it still remains our first line therapy. And, if someone is unable to have, significant disease score reduction after 4 weeks of a trial of at least two different types of NSAIDs, then we would move on to more powerful medicines such as the biologics.
Mhm. And can you walk through a current algorithm for a young patient with axial dominant disease and a history of, let's say, uveitis, IBD, given guideline preferences for monoclonal TNF inhibitors in those settings?
Right. So, again, each patient is totally individualized. In a patient who might just have pure, axial disease, just pure spinal disease, then sure, we'd go ahead with a trial of NSAIDs. And we would just keep that on if that is enough to reduce the symptom burden and to bring down the disease activity score. Then we would just continue the NSAIDs. If there is failure to an NSAID, then our next step would typically, sometimes for ease of insurance, might be tumor necrosis factor alpha inhibitors such as adalimumab or Humira or infliximab, for example. And if there is failure to that or inadequate response to that, then we would move on to an interleukin 17 inhibitor such as secukinumab or ixekizumab. And then if there's failure to respond to that, then we might move on to a JAK inhibitor, which is a targeted synthetic biologic drugs such as upadacitinib or tofacitinib. I would say though, all of this also depends on the patient's comorbidities or other associated diseases that they have. For example, if someone does have inflammatory bowel disease, then an interleukin 17 inhibitor, such as secukinumab or ixekizumab, is actually contraindicated because that could actually make inflammatory bowel disease worse. So it really depends on the patient's comorbidities.